pleased to welcome you to this conference on patient cost sharing in prescription drugs. We're going to talk about three issues during this conference. One is the issue of the Medicare Part D benefit design. Then we're going to talk about some issues that affect more commercial coverage, the issues of coupons provided by manufacturers to support use of their drugs by individuals, and finally the issue of whether in either Medicare Part D or commercial programs, whether rebates on some drugs should go roughly to the patients who use the drugs, or as they are today, to lower the premium of the prescription drug plans. We have two panels. The first one is on Medicare Part D, and the second one is on the other two issues. And we're really pleased that since we planned this conference and announced it, the issue has become more timely with the proposals in the President's budget for an out-of-pocket cap on Part D and a different way of handling the rebates in Medicare Part D as well. So I'm going to start off the first panel by introducing our first speaker, who is Erin Trish from the University of Southern California, the Schaeffer Center for Health Policy and Economics.
All right. Well, thank you very much, Paul, for the introduction, and thank you for being here. I'm going to focus today on talking about a proposal to cap out-of-pocket spending in Medicare Part D. But before we get into that proposal, I thought it was important to just kind of put this in the broader context and recognize that Medicare Part D has been an incredibly successful program overall. We've seen a considerable increase in access to affordable prescription drug coverage for seniors, with robust market participation from market participants, as well as a program coming in below expected costs. So one of the concerns here, though, has been about continued high out-of-pocket spending, particularly for seniors with relatively high prescription drug spending. So what's driving that concern? Well, if you look at the initial standard benefit design in 2006, or the first year of Part D coverage, what you can see is that beneficiaries started in kind of a traditional metrics of an insurance policy with a deductible, after which they faced 25% coinsurance through something called the initial coverage period. But beneficiaries who spent more than about $2,200 in prescription drug spending then entered into something called the coverage gap, or the donut hole, where they faced the full cost of prescription drugs. This led to a lot of concerns about affordability for seniors, about utilization, and other types of concerns about health outcomes. And as a result, there have been the Affordable Care Act included policy provisions that really work toward reducing out-of-pocket spending or filling in this donut hole. So what we've seen is that progressively, and now initially by 2020 and now by 2019, beneficiaries will just face 25% coinsurance through both the initial coverage period and also through the former donut hole. But none of these policies have really focused on this kind of final portion of the benefit phase called the catastrophic coverage region. So beneficiaries with very high prescription drug spending, so in 2018 about $8,500 in total prescription drug spending, move out of this donut hole phase and into something called the catastrophic coverage period, after which they face 5% coinsurance on all prescription drug spending for the remainder of the year. So this is an uncapped benefit with unlimited potential out-of-pocket spending for these beneficiaries. So in thinking about what that means for beneficiaries and what capping that out-of-pocket spending at that level might mean, it's important to recognize that there are two kind of fundamentally different groups of beneficiaries in the Part D program. Lower income beneficiaries qualify for something called the Low Income Subsidy program, where the federal government pays not only for the premiums for these beneficiaries, but also either all or the vast majority of their cost sharing. So in the initial years of the Part D program, these LIS beneficiaries represented about 40% of total beneficiaries, but they're much more likely to reach catastrophic coverage. And so the vast majority, or essentially over 80% of beneficiaries that reached catastrophic coverage, qualified for these low-income subsidies, and therefore they were insulated from this cost sharing. And this kind of uncapped or unlimited benefit wasn't really applicable to them because the federal government was financing these cost-sharing provisions for them. But what's important to recognize is that fundamentally the Part D market has changed since the initial years of the program, and we've seen a considerable growth in the number of non-LIS beneficiaries who reach catastrophic coverage. So what that means is that there are now many more beneficiaries that truly do face this kind of risk of uncapped prescription drug spending and are susceptible to high and unlimited out-of-pocket spending in the absence of a cap in Part D. Now, not only have they increased in terms of the number of these beneficiaries, but their spending has also considerably increased over time and projected to continue to do so, suggesting that not only are there more of them, but they are potentially susceptible to much higher levels of out-of-pocket spending as well. Now, it's certainly the case that the provisions to fill in the donut hole have helped these beneficiaries in terms of reducing their out-of-pocket spending. So this is an analysis that we've done looking at a specific sample of non-LIS beneficiaries who take specialty drugs and looking at their out-of-pocket spending in Part D, but breaking that up in terms of below the catastrophic coverage threshold and above the catastrophic coverage threshold. What you can see is that with the introduction of the ACA's provisions to fill in the donut hole, there was a significant reduction in out-of-pocket spending among these beneficiaries below the catastrophic coverage threshold. But at the same time, we continue to see increased out-of-pocket spending resulting from the spending that they incur while in the catastrophic coverage threshold. So this is the spending based on that 5% coinsurance liability off the list price of drugs. And you can see that this continues to grow over time and that the ACA's provisions did not, in fact, reduce that portion of the out-of-pocket spending. We wouldn't have expected it to. So on net, what you can see, or kind of the main takeaway, is that yes, the provisions to fill in the donut hole did result in a kind of one-time downward shift in out-of-pocket spending for these beneficiaries, but that their out-of-pocket spending continues to grow and that they continue to be susceptible to the lack of a true out-of-pocket cap or true insurance protection in this program. So that leads me to make a recommendation that it's time for Part D to consider implementing, or for policymakers to consider implementing a cap in the Part D program, a true out-of-pocket cap, to provide true insurance protection for beneficiaries from high and currently unlimited out-of-pocket spending. Now, others have also kind of shared this vision or shared these recommendations, in particular as a standalone policy in the case of Wyden's Senate proposal, and in conjunction with other reforms in the case of the MedPAC recommendations, and most recently, as Paul mentioned, in the President's budget on Monday. Implementing this type of out-of-pocket cap would be consistent with other reforms that we've seen recently in other insurance markets, so particularly in the commercial insurance market. The Affordable Care Act requires that all commercial insurance policies, so both employer-sponsored policies as well as exchange policies, that they include a true out-of-pocket cap on spending for all covered essential health benefits, including prescription drugs for these commercial plans. So beneficiaries do indeed have the protection of this true out-of-pocket cap in the commercial market. Now, the Medicare program itself does not include a true cap on out-of-pocket spending in the Part D program, but also in the Parts A and B programs that cover medical services. But beneficiaries have the ability to cap their out-of-pocket spending for these medical services covered under the Parts A and B benefits by either enrolling in a Medicare Advantage plan, which are required to have a cap on out-of-pocket spending, or by choosing to enroll in certain Medigap or other supplemental policies that may offer this benefit. But no such protections exist in Part D, and beneficiaries have no possible way to cap their out-of-pocket spending in Part D, and it's important to note that even in the case where a beneficiary is enrolled in a Medicare Advantage plan that also offers Part D coverage, they face a cap on out-of-pocket spending for the medical services covered under the A and B benefits, but not on the Part D side of the prescription drug spending of those benefits. So what might be the impact of implementing such a policy? So certainly we would reduce out-of-pocket costs for this growing number of non-LIS beneficiaries that reach catastrophic coverage, so over 1 million beneficiaries in 2015. But additionally, this would provide financial protection or kind of true insurance protection against the uncertain potential cost or the potential for very high out-of-pocket spending among not all of the non-LIS beneficiaries in the Part D program, which are also growing both in number as well as a share of overall Part D beneficiaries. So if you took this out-of-pocket spending and capped it, that spending has to essentially go somewhere. And so if we shifted that to become plan liability, you would expect plans to in turn increase premiums, which would result in a premium increase spread across all beneficiaries, and also a resulting federal spending increase, although divvied up in different ways across the different ways that the federal government finances the Part D program. So what do I mean by that? I'm going to break through that now here with an example of, we've done some analysis of the 2013 Part D claims, And what we find is that in 2013, there was about $27 billion in total spending in the catastrophic coverage region across all beneficiaries. This is based on the kind of list price or the actual pharmacy paid price. Now, of that, about 5% of that is the beneficiary liability, or about $1.4 billion in total spending. So if we implemented a cap at the catastrophic coverage threshold, this is the additional spending that would be transferred and would become plan liability rather than beneficiary liability. In turn, plans would increase premiums for all beneficiaries, and because the federal government subsidizes the premiums for all beneficiaries, this premium increase would be split partly among beneficiaries who would see an increase of about 85 cents per member per month, and also partly, or in large part, as a federal spending increase of about $1 billion in increased spending on the direct subsidy program. But as I mentioned, the federal government also pays the premiums for the LIS beneficiaries, so we would see an increase in federal spending on the LIS premium subsidy component of federal spending. Though it's important to note that among this 5% beneficiary liability, as I mentioned, for the low-income subsidy beneficiaries, the federal government is already paying that, what would be kind of the 5% beneficiary liability in the form of the low-income cost-sharing subsidy. And so if you capped this liability and shifted the liability to the plans for both the LIS and non-LIS beneficiaries, that would be a significant reduction in federal spending on the program that subsidizes cost sharing for low-income beneficiaries. So what does that mean taken all together? We'd expect a relatively modest impact in terms of both a modest increase in beneficiary premiums as well as modest overall federal spending on this policy proposal. But it's important to note that the cost of implementing such a proposal would increase over time because we see increasing and continued trends toward increasing spending in the catastrophic coverage phase of the Part D benefit. Now, it's also possible that capping out-of-pocket spending, you could think that this would induce some behavioral responses either on the part of beneficiaries or perhaps on manufacturers in terms of their pricing decisions, which could result potentially in kind of a unintended consequence of higher spending or higher prices, though it's not necessarily clear that moving from a policy of 5% coinsurance in catastrophic to 0% would have a significant impact in this regard. But it's important to note that while capping out-of-pocket spending would provide true insurance protection for beneficiaries against potentially high and unlimited out-of-pocket costs, it would not address other concerns about the Part D program, namely the continued and persistent increases in federal spending in the reinsurance, or kind of the federal subsidy of catastrophic spending. Other kind of Part D incentives that are motivating or potentially driving this spending are the underlying growth in net drug prices. And so it's possible that in conjunction, particularly in conjunction with implementing an out-of-pocket cap in Part D, that some of these other complementary policy proposals may become more attractive as a means to think about, if we're concerned about the increasing cost of implementing a cap, an out-of-pocket cap over time, there are other complementary policy reforms that could help to potentially rein in or address this growth in Part D spending in the reinsurance or in the catastrophic coverage region. So things like revamping the federal reinsurance program and essentially shifting more liability from the federal government to the plans. Potentially things like excluding what currently counts. So currently in the donut hole, the manufacturer finance discounts for beneficiaries count toward their essentially true out-of-pocket or what accumulates as their spending that moves them through the benefit phases. So a proposal to essentially remove that from the calculation of your out-of-pocket spending over time. And also a policy proposal, which we'll hear more about in kind of general in the next proposal, or excuse me, in the next panel, focused on requiring plans to pass a portion of rebates directly through to beneficiaries at the point of sale. So each of these proposals would essentially be expected to reduce the number of beneficiaries that reach catastrophic coverage in some way and potentially reduce spending that occurs in the catastrophic coverage region. Though it's important to note that they would have different impacts in terms of their actual effect on beneficiaries' out-of-pocket spending. But nonetheless could be implemented in conjunction with an out-of-pocket cap that may reduce some of the concerns about the increasing cost of implementing this type of policy over time. So with that, I think I'll wrap it up just by noting that my policy recommendation is that it's time to consider implementing, or it's time to implement a cap on out-of-pocket spending in Part D in order to protect beneficiaries from high and unlimited out-of-pocket spending, or essentially to turn this into true insurance protection for these beneficiaries, and that complementary reforms could be considered in conjunction with this proposal as a means to address kind of broader concerns about federal spending on the Part D program, and in particular in the catastrophic coverage region.
Oh, thank you very much, Aaron. Next, we'll hear from Doug Holtz-Eakin, President of the American Action Forum.
Well, thank you, Paul, and thank you for the chance to be here today. When Paul invited me, he told me my job was to be disagreeable, and I'm well suited to the task. But I do want to thank Aaron for just a fantastic presentation and a very clear sort of discussion of the issues. When I first saw the title for this, I thought it was just wrong, right? Because the question isn't, do we want a cap in Part D? Because we could put the cap at $10 million a year, and we'd have exactly the same program we have right now. So the real question is, do we want to lower the cap to the current catastrophic maximum, and are we willing to accommodate the trade-offs that come with that? And I think Aaron has laid out very clearly the kind of issues that arise. You're going to have higher premiums, and beneficiaries are going to see that. You're going to have higher federal government spending. You may see changes in the formularies that are offered in Part D. And you just have to decide whether those are trade-offs you are willing to accept in order to put this insurance backstop in place. I want to at least say a few words in defense of the U.S. taxpayer and the idea that putting them on the hook for this might not be a good idea. It is currently fashionable to blame the U.S. budget outlook on the tax bill that was passed in December, but I want to remind everybody that the CBO baseline in January of 2017, prior to any such legislative action, contained $10 trillion of deficits over the next 10 years, and that was driven by large growth in federal entitlement programs, in particular federal health programs, like the ones we're discussing right now. And so I don't think one should casually add to that bill because it's already one that we can't pay. And we ought to think hard about the design of these programs. I want to say a few words about that. And the mirror image of the large growth in beneficiaries' costs in the reinsurance area is federal spending in the reinsurance area. They're picking up 80% of this right now, and it's growing well over 15% a year. So this is already a problem. I'm not sure we want to add too much to it. So that's an issue. And the question is, if we did that, who are we doing it for? Well, as it turns out, we're doing it for a very small part of the Medicare population, about 2.5%, who are by definition the most affluent of the Medicare population. And it seems like an odd place to spend your scarce taxpayer dollars if you really don't have a lot of choices. So, you know, that's really the issue, and people are going to come down in different places on it. That's perfectly understandable. But I'm at least worried about the outlook for the program. I have to admit this. I was a CBO director when the Part D program was birthed and implemented. And I've always admitted that I like it more than I like my children. So I want to take care of it over the next foreseeable future. And there are some developments here that I think are a little bit troubling. So as Aaron mentioned, there are these proposals to accompany the catastrophic cap with changes in the reinsurance. And I want to talk a little bit about the president's proposal, and which is a mirror image of the MedPAC proposal as well. Basically, what this would do is it would put in the catastrophic cap, and then in that area, the insurance plans would have to pick up 80% of the cost, and the federal government would pick up 20%. Right now, the federal government is picking up 80%. So the idea is to put the plans on the hook for more liability and give them better incentives. That all made sense. Accompanying that is this notion that when you're counting the dollars to get to the cap, you no longer get to count dollars that are essentially paid by the manufacturers in the donut hole, which was this 50% discount. And so, yes, you're on the hook for more liability once you get to the catastrophic region, but it takes longer to get there. People are spending more genuinely out of pocket, and it raises the possibility that you're going to have beneficiaries paying more, not less. In fact, some will. There's no question about it. And so that's something to think about. The troubling development happened in between the president's budget and these original proposals, which was they passed the Bipartisan Budget Act of 2018, and in it they changed the rules on what's going to happen in the donut hole. And now the manufacturers, instead of being on the hook for 50%, are going to be on the hook for 70%. And we were on track to have this be a split which was 50-25 for the plans and 25 for the beneficiary. And they didn't take that additional 20 off the beneficiary. They took it off the plans, which I'm just going to describe as mystifying. And I mean, I don't understand it. We do not ask auto parts manufacturers to kick into auto insurance. We don't ask the builders to kick into homeowners insurance. This is a bizarre thing. But the upshot is, if you now go with something like the president's proposal in the presence of this 70% share for the manufacturers, the plans themselves are only on the hook for 5% in the donut hole, and there are relatively few people who are going to get to the catastrophic region, and so they're not on the hook for much in the way of liability in the donut hole or in the catastrophic region. And it's not my idea of an insurance plan when you pay premiums and they don't cover any liability. That seems odd. And so I want to thank Aaron for floating this proposal. I think the design issue is an important issue that ought to be addressed, but it's going to take looking at all these pieces simultaneously, because right now we're on track in this piecemeal fashion to end up in what I think is a very bad design.
Oh, thank you, Doug. Next, we have two reactors from the Congress. There's Liz Jurinka, who is the Chief Health Staff on the Democratic side for the Senate Finance Committee, and Nick Ulicki, who is a professional staff member on the Committee on Ways and Means Subcommittee of Health on the Republican side. Liz, would you like to speak first?
Sure. It's a hard act to follow, Doug. The congressional reaction to Doug's reaction of what we did in Congress last week. I like it. I think it's a good way to start this. But first I want to say thank you. Thank you to Paul. Thank you for having us, for having Nick and I to be able to give this congressional reaction. I see a lot of friendly faces in the audience, so hopefully for Q&A we can keep them friendly. I see Liz here and Dr. Rivlin, and it's really a pleasure to be here this morning. I think Paul's comments were exactly right in the very beginning, that this panel is particularly timely given the president's budget and what happened in Congress last week. Selfishly for me, Senator Wyden has a lot of pride of authorship, and so to see many of his policies at least alluded to in the president's budget, and then have such, I would say, great reform of at least closing the donut hole last week, in addition to extending CHIP for 4 years and, of course, passing the chronic care bill. This is a great time for us here at the Finance Committee, so I will just say that. I do think that, however, having said all of that, that Aaron's comments are also timely. The notion that we are making improvements to the program and for beneficiaries is it's good. Oh, absolutely. Sorry. Thank you. Excuse me. The idea that we don't have an out-of-pocket cap for beneficiaries is something that we should be concerned about. Having said that, I think that it's not a problem. Having said that, I do think the financing, and I agree with Doug, that the taxpayer, the question of how to pay for it is always going to be something that we have to deal with. And I actually do agree with Doug that the notion that plans are not responsible, particularly in reinsurance, or what their role in reinsurance is something that we should be looking at in Congress. I think that the notion of restructuring Part D, however, if you say that, it's like a lightning comes and strikes you in Congress, because Part D is so popular and it is such a successful program. Having said that, the cost of Part D is increasing, and I know that that is blasphemous to many because it is such a prized program, but it is true nonetheless. And I think part of that really has to do not only with the underlying structure of the program, but also the question of what is the role of the manufacturer and what role they have in setting the launch price to begin with. There were a lot of proposals in the president's budget that just came out to address, I think, what we would call maybe the web, if you will, of how drugs are both paid for, how the beneficiary pays for them, what have you, whether it's point-of-sale rebates that was included in Senator Wyden's see-through bill, or whether we are going to have an out-of-pocket cap. But there's nothing in that proposal that really directly addresses the issue of launch price. And so if we have to figure out, both in Congress but also within the administration, what are options there? My boss has said many, many times he really enjoys having the private sector have a role to play in healthcare, but we also want to make sure that healthcare is affordable. And so if people can't access drugs that they need, then we're kind of missing the mark. I think, reinsurance in particular, however, should be, I think, one of the next things that Congress deals with when it talks about Part D and changes to Part D. I mean, just a few facts. Spending on Part D grew by nearly 60% between 2007 and 2014. Reinsurance payments have doubled over the last decade and are becoming the number one or the single largest component of Part D spending. And reinsurance is this kind of hidden component, if you will, not necessarily to people in this room, but to folks at home. They don't understand how reinsurance works, but the government is on the hook for an enormous amount of that spending. So we really do need to take a look at that if we're going to keep this program as successful and accessible as it is. And with that, I think I'll pass it to Nick, and I'm really looking forward to your question.
Hi. Hi, everyone. Nick Ulecki with the Ways and Means Health Subcommittee. Apologies first for being a little tardy. My driver's cab just died about 4 blocks away and just sort of sprinted the rest of the way. And I have to do this at the beginning just to save my job, but these are my thoughts, my opinions, not that of my chair, my conference. Pretty much everyone in the pecking order above me, which is a lot of people, you'd be surprised. The fortunate part about being last is that I get to keep my comments short and leave it mostly up to your questions. But I think the words that I wanted to speak with you today are very different than the statement that I came up with 2 weeks ago that I just kind of tossed out on the way here, because the world has dynamically changed, I think, since what we did last week. And I used the royal we, and what happened with the president's budget. I think that when you look at what we did in the budget deal last week, it's likely not what we would have come up with in the House in our conference, to be completely frank with you. I think that Doug had made a couple of good points there and I think that we're kind of still a little bit of soul searching ourselves on, have we left the soul of the Part D program intact and kind of the intent of what we were trying to do after what we did. And, some of the details aside, now I think we're looking at, what's next? What are the possibilities? What are the things that we need to do to ensure that we are working as a group to provide kind of the essential, what's essential to be access for beneficiaries who need the drugs and truly cannot access them, whether it's due to cost or whether it's due to the plan formularies. And so that brings me a little bit to this concept, and I think that both Aaron and Doug touched on it a little bit, which is responsibility, personal responsibility. And I don't mean that just on the beneficiary aspect. I mean it on the entire continuum of when a drug is manufactured all the way through to all the folks that touch how it is priced and how it's handled and how it gets to the beneficiary along the way. Because I don't think that the answer, honestly, to the issue of drug pricing and how are we going to lower prices, how are we going to make sure that people have access is an issue that we alone in the federal government are going to be able to sit down in a room and answer. It's an issue I think that physicians need to be a part of. I think when we're talking about prescribing and prescribing habits and how the Medicare program itself works, where I think we are largely a drugs first program, I think that we need to look at the beneficiary level as well and talk about personal responsibility there, and I think that the raging debate between the manufacturers and the benefit managers as well needs to come down to kind of a more rational side of instead of throwing barbs out there, we need to kind of come together and say, what can we do all together to make this problem work along the continuum? So speaking from my angle of it, I do think that there is a general agreement that 15 years ago, the debate over drugs was accessibility. Doug's right. I mean, when he was over at CBO, what we were debating was, do seniors have access to these drugs? I mean, the world has dynamically changed on the side of innovation over the course of the last 20 years. And I think that in that administration, it was kind of this point of, wow, we need to figure out a way to give seniors complete accessibility to this series of drugs as the baby boomers start coming in so quickly. And so as accessibility started getting solved along that time, I think we have now reached this issue of accessibility because of affordability. And so speaking on kind of both sides of it, we're kind of hitting a point where the debate that we are having and amongst our staff and amongst the staff of our committee members and RLAs and everybody as we sit down and talk about this issue is that how are we going to take head on this concept of innovation? We're now seeing curative drugs, right? We saw what happened with Hep C a couple of years ago and what that did to the system. And I think that one of these issues of how are we going to pay for these, how are we going to pay for these drugs? How are people going to pay for drugs that cost, say, $1 million, but it cures you of something for the rest of your life? You know, and so I think that the current way that we're doing things is working, but we need to make sure that the kind of tsunami that's coming is something that we're prepared for. I mean, I think that we're all kind of on the edge of our seats when we talk about things like dementia and Alzheimer's, every time a company gets really close. And I think we're all kind of, I mean, the company's probably pretty sad, but we're all saddened when it doesn't work out or, you know, we don't get to the end point that we want to get to. But are we truly ready for a drug that will slow down or reverse the effects of dementia as a healthcare system? To be honest with you, we're not. We don't have the alternative payment models in place for this population. Honestly, I think we dropped the ball highly for this population, and it's something that we are working on to be prepared for. But if we thought that the Hep C issue that is a drop in the bucket to what happens to the entire healthcare system, when we're seeing folks with early onset Alzheimer's in various parts of the world passing away at the age of 30, everybody who's ever forgot their keys is going to be wanting to take this drug. And so, you know, it's something that I think we all need to work together to be prepared for. And I know that we are willing to sit down at the table and have this discussion. Now, again, if we had started this discussion, do I think that we would have agreed to some of the changes that were made last week if it wasn't writ large part of a larger budget deal? Probably not. And so we are having discussions with the administration on their policies as well, and we're still kind of in the digesting track of all the policies. But you know, I look forward to working with, I think, a lot of the smart minds in this room, in the audience, and up here at this table on what the future really holds on this. Thank you.
Thank you, Nick. I'd like to throw out a question to any of the panelists that would like to answer. To what degree will the President's proposal with this treatment of catastrophic coverage, in a sense, be a catalyst for discussion of many of these other issues in Part D that all of you have brought up?
I think it's going to be an important catalyst. I mean, one of the things that has happened between 2003 and now is that many people who were around at the birth of Part D, have now left Congress, and a lot of people who were associated with the program are not around to explain the original intent and the integrity of the policy design. It's now viewed as just another government spending program. That was far from the case. It was consciously crafted to be a competitive system with private insurers bearing the financial liability, giving them strong incentives to negotiate effectively with the manufacturers, and thus provide the access to these drugs for seniors and give them insurance against the out-of-pocket costs. And that insurance did not exist in nature. I mean, there was no private product against the financial costs of outpatient prescription drugs. So that whole policy design, I think people have lost track of why it was designed the way it was, and it has worked incredibly well. I always remind people that the Part D program had in it government fallback plans in every region because no one believed, that's not true, many people did not believe that it would work and that private people would step up and provide this product. They've never been used. It has really worked much better than anyone has ever dreamed. And so my concern with things like the donut hole are not that I care about pharma versus the insurers. I actually don't care about either of them a bit. But if you think about what they're doing, in the donut hole, this 70% is really just a tax and spend program that does not take advantage of the incentives of insurers. They're just going to take it from the pharma guys, and you could have a tax that did that, and distribute it out to the beneficiaries. That was not the program design. And so we're slowly undermining it. And I think it'd be great if we had a discussion about what do we want out of this program, not from just a total spending point of view, but from the incentives that the program embodies.
You know, what's interesting, Doug, is that when the program was passed, there was an expectation, which proved to be generally true, that there was a particular benefit design in the law, but the plans had the flexibility to alter it, and they did, except when it came to the donut hole and the catastrophic, because at least it either would have driven the premium up too high, and it would have provided a selection spiral, which one prominent company, Humana, found when it tried to offer brand name drugs without a donut hole.
Yeah, and it's just as a matter of perspective, that's right. But you know, most people aren't in the donut hole or in the catastrophic region. 2/3 of the beneficiaries are in the initial coverage part, and so for the vast majority of seniors, this discussion really doesn't apply. And it's the smaller subset that are in those areas that we have to worry about.
But I guess I would agree and disagree. And to the extent that Nick is right, and I think he is, that we are looking at curative treatment, we are looking at new and innovative therapies that are more and more expensive. It's not so much that the 2/3 are not in the coverage gap. It's in the event that more folks are getting drugs that they're right. It is. That's right. But like to the extent that drugs are becoming more and more expensive for a variety of different treatments and diagnoses, more people are going to potentially be in that coverage gap. But I think the other point, though, or going back to what Paul's original question of what is the I take it what is the impact of these policies being in the president's budget. The president has the bully pulpit. I mean, he has the largest stage. Mm-hmm. The fact that this policy is in the budget means it is a shift in terms of potentially where this administration is in thinking about drugs, which I think is important. I would also argue, the president's budget also includes Graham Cassidy, which we will throw ourselves in front of a train to let that happen. So, I mean, there's a balancing act of how much weight we want to put on any one particular policy. And that'll be the royal we, right, Nick? We're going to throw ourselves in front of that train. Right. So, what I would say, Senator Wyden has had his RX cap bill out there for quite some time. So now to have the administration echo this idea of this additional protection for some of the most vulnerable is important. It's important to our office. I think it's important to Democrats. I think the question, I guess, I go back to is this a signal of the administration that they want to take on the issue of pharmaceutical pricing and spending, or are these going to be policies that end up in a document that is kind of paraded across Congress for a week, which, don't get me wrong, we had the secretary up before the Finance Committee yesterday, as I mentioned before, and it is important. But what happens next? What does the administration do? Does the secretary say these are things that he is going to call on Congress to do? And if that is the case, then we need bipartisan support, because if I've already mentioned, Senator Wyden is already there. Maybe it's some of the other aspects of how we finance or restructure, fine, but it's going to require bipartisanship at all levels of government in order to actually move any of these policies forward.
Other thoughts on anything on the panel before we go to questions?
I'll say one more thing and then I'll shut up. So I think it's just important to note that this sort of the innovation and these expensive drugs are not, that's not independent of the incentives that are in Part D and elsewhere in the payment system. I mean, the fact that insurers don't have any donut hole liability and have only 15% of the catastrophic region says that they don't have a real big incentive to stop purchasing the very expensive drug. And if they were on the hook for more, they might be saying to the manufacturer, that's great, but this other one that's cheaper and does nearly as well as what we're actually going to put in the formulary. And so I think we need to think about the whole thing pretty carefully.
Well, and just on that, Doug, is it just the two of us? I'm just kidding. It's like we're going to have like a little back and forth here.
No, I said I was going to shut up. It's all yours.
Don't promise something that you can't deliver on, Doug. No, I think the other thing is that policy did not. There are a few times in Congress when you pass something without the input of CBO or other folks. CBO, one of the reasons that it actually ended up in the budget, besides there being a four-way agreement, was that there was savings associated because because plan bids were not going to be as high, premiums would lower. So the notion, I agree with the idea that the plan does need to have a role in this to, help negotiate, for all intents and purposes, with manufacturers to lower prices. But what CBO also found, or at least what they said, was in in shifting this to the 70% or 75 or 60, whatever it is, that the plan bids would actually go down, and that therefore would help premium and save the government money. It wasn't necessary. The savings was from the federal spend, not necessarily in premium. So, to the extent that the plan now is going to have a less expensive option, I think that's something else to think about. But I understand what you're saying, and I agree that we need to continue to think about what that role is of the insurer.
I think also just picking up on some of your earlier comments, Doug. So now we're in a situation where, in the initial kind of introduction, there was an intention to engage plans in a particular way. Now we've kind of piecemeal, as you've pointed out, filled in these different provisions. Plans face very different incentives at different portions of the benefit phase, or kind of, and essentially also keeping in mind that that this is all based on the list price of spending. So we also have these rebates, and now plans on the hook for 5% of spending, plus the rebates that they're bringing in. I mean, you just kind of recognize that if you were to design this now and recognize and say, this is the benefit design we want to get to or we have today, you may think about a very different way of engaging this plan behavior and incentives to kind of get at the outcomes that you're achieving. And so perhaps it's time to rethink more broadly. Now that we've come to a different place and what this benefit looks like, is it time to think about how can we best use the market forces that plans have to offer in kind of getting the outcomes we want, and perhaps protecting beneficiaries from high out-of-pocket costs in conjunction with that.
Good. Just one more closing thought. I think what the point Doug brought up about engaging the insurers and having them have something at stake is very important when we're dealing with very expensive prescription drugs. Because, as things have evolved with $100,000 a year treatments or more, we can't make much use of patient cost sharing as a device to control utilization. That's really just a matter of how much the patient kicks in. So in a sense, the authorizations, the management that the insurers bring have become much more important in the drug area than they used to be. And if we disable the insurers, then it's uncontrolled. This would be a good time to go to the audience. We've got 4 really good panelists, and I just want to ask you to direct your question to went off. Just suggest ask your question to a particular panelist who would speak first. Fiona? And please wait for the mic. Sorry.
Just in time.
Abby? Yeah. No, actually, we have a lot of people online, so we want them to hear the question as well.
So I had a comment for Doug, but my question's for Erin. So I think one of the true purposes of insurance is to smooth financial risk. So I think it is odd to say if we don't want to spend another federal dollar, the place we don't want to spend it is for the person with uncontrollable, uncapped costs. And instead, we want to spread it evenly to the tune of 30 cents a person across the population. So we could just take $1 from everybody in tax revenue and give 30 cents of it to each old person, and that would be what we're doing now in Part D. Or we could take $1 from each person and actually insure somebody who we don't know the identity of that person today, but they're exposed to some really large cost, and we would all prefer, as people who don't know whether we're going to be the sick ones, to have that insurance. So my question for Erin is, you didn't show a distribution of those costs. I'm surprised about that. If the point of this is to insure the really extreme cases, which none of us want to be, how many of those are there and what do they look like? If all the people in the catastrophic region were paying $500 in the catastrophic region, that's very different than if most of them are paying $2 and somebody's got a bill of $1 million.
Yeah, no, I think that's a very important point, and there is a distribution and there are some who spend, who essentially just modestly cross the catastrophic coverage phase and have very little out-of-pocket spending. There are some who have very high out-of-pocket spending in catastrophic coverage. There are also some for whom this is a persistent year-over-year type of condition, and they'll be taking these drugs for the rest of their life. And there are some for whom this is kind of a one-off, this is something that we cure in this year. And so I think it's a really important point that this will impact beneficiaries in very different ways in terms of the actual out-of-pocket spending.
I have a quick question for Doug. Charles Fournier with a type 1 diabetes
Could
defense
you
foundation.
identify yourself, please?
Yes, Charles Fournier with a type 1 diabetes defense foundation. This morning we heard a lot of different definition of cost price, cost of drug, but the one word we never heard is negotiated price. And can you explain what was the original policy intent in having insurance company negotiate price and convey that negotiated price to the beneficiary of the plan, and whether or not that policy intent has been fulfilled today?
So if the original design and the intent was to have multiple prescription drug plans competing to get beneficiaries, and that the power of that competition would force them to negotiate strongly with manufacturers for as low a drug price as possible so that they could keep their premiums down and attract the beneficiaries into the program. And that has, by and large, been pretty successful. There are these issues now about the nature of how you get to the final negotiated price and how much rebate gets delivered and at what point it gets delivered. And that's the next panel, and it's a good discussion to have. But I think the big picture, the intent was very simple. It was to have powerful competition for beneficiaries, induce powerful competition for lower drug prices from manufacturers, and that has by and large worked well.
Okay. I'm Dan Klein with the PAN Foundation. We're the largest independent charitable foundation helping cover out-of-pocket costs for patients on Medicare. So we deal with these patients every day. And I want to first start by reminding the panel that the people we're talking about that Doug referred to as the most affluent in Medicare are people who are 150% of federal poverty level and above. Typically, we're helping people between 150 and 400% of federal poverty level. These are folks who are already spending in excess of 20% of their income on healthcare-related out-of-pocket costs. So we're talking about people with Parkinson's, people with MS, people with cancer. And if they're lucky enough to make it to the catastrophic threshold and still be able to fill their prescriptions, then at least their out-of-pocket costs come down. But the reality is that many of them can't even get to that point without getting outside assistance. So when you talk to people with cancer, and you talk to people with MS, and you talk to people with Parkinson's, well over 50% are unable to afford their out-of-pocket costs before they get to the catastrophic threshold. So I think there needs to be a little reality check about what we're talking about. We're not talking about the need for consumerism. Nick talked about increased consumerism. But I'd remind the panel that, again, people on cancer, or with cancer, people with Parkinson's, people with MS, people with serious illnesses often don't have a lot of choices about what medication they're going to take. And in some instances, in fact, in many instances, there isn't a cheaper alternative. So again, I think it's easy to make the policy question so complex that we forget about the near-term needs of patients. So we had a call the other day. I had a call from a woman who was trying to renew her grant. She has MS. She takes a drug that keeps her from falling down.
Yeah, could you wrap it up?
I will. So she needs help covering $50 a month in copay, or she can't take this drug. And that's who we're talking about. So I just want to remind folks that there's a very practical side to this discussion.
Okay, thank you. Yeah, Mike Miller over there. It's coming.
Hi, Mike Miller. I'm a longtime policy physician here in DC, about 30 years. Doug brought up the concept of incentives for the plans. I wanted to go back to, broaden that to incentives for the drug companies and ask this question to Elizabeth, because in my analysis, what was in the budget bill, it actually increases the incentives for manufacturers to raise their launch prices. Because if they're going to be told they've got to give it a minimum of a 70% discount for these drugs in the donut hole, which could be more than 70% if there's rebates on top of that, and that could be exacerbated if TROOP doesn't count towards getting to catastrophic. Is that any part of the discussion? Was that thought about when this proposal was developed? And since you've said that Senator Wyden is very concerned about launch prices, this seems to go in the opposite direction. Thank you.
Sure. So we're talking about the budget last week as opposed to the budget on Monday, which is the budget bill versus the budget proposal. Got it. There's a joke there somewhere, I know, but no, I think no, I appreciate that. No, I don't think. I think the issue that drove that particular debate last week was, number one, closing the donut hole sooner, right? Accelerating the closing of the donut hole by a year. That was really the genesis of this. And then I think for those that were in that discussion, I think the other question was, how do you do that? And and what savings does CBO give you for all the various options? I think that when you're talking about a $280 billion budget cap increase, some of that, you know, the idea of the dollars and cents of what policies get you drives a lot of that debate. The issue of launch price, though, I think goes well beyond that one particular policy. Right? The notion of, I mean, in a crass way, right now, companies are going to launch at whatever the market will bear, whether it's a 70% within that donut hole or not. And that's how it's been, and you know, it is what it is. I think that that's okay in a lot of ways. But, you know, is that concern what drove that? No, not at all. I don't think that, and I don't know that policy, no one has told us at this point that that is going to be a real reason that launch prices either go up or go down. In fact, I think some folks, at least what we have heard a little bit in coming out of this is what the impact on the plan is actually going to be. Are plans going to change what they cover? Are you going to have plans that now want to tailor a plan? Is an insurer going to tailor a plan to target people that are not going to get in the donut hole, or those that are going to only get to catastrophic? I think the bigger issue, and I don't know, we haven't looked at any kind of data or analysis that shows that one way or another. I'm just saying that this is kind of in the ether now in the last week, some side comments that we've heard. I think the bigger question is also going to be reinsurance. I go back to that. That is the sleeper issue here. The notion of 70% for the manufacturer, I think, is in some ways a sideshow to the amount of money that we are spending on reinsurance. And to the extent that there is a role for the plan to negotiate a better deal for catastrophic or for, you know, the highest cost drugs, that's really where we need to go.
Thank you very much. I guess my question are for the congressional people.
Identify yourself, please.
My name is June O'Connell. I'm an attorney. I'd like to ask about generics and also the fact that with Part D, enrollees can switch plans each year without penalty, unlike a gap plan, for instance. That as long as you're within your window, you can go from Medicare, Plan D, Acme to Plan D box with no penalty if you're in the time frames. So there has been an emphasis on generic, going with generic in a lot of these programs, but generic isn't cheap anymore, depending on the number of suppliers. So I wonder if you can kind of discuss the role of how you see monitoring generics within these Plan D options.
Okay, great. So I think that, I mean, the generic utilization in this country is, you know, some of the highest that it's ever been. I think that's a good thing. We're looking at close to 90%, which is great. I think that your point that you're making, I think that some of what I'm hearing is, to the extent that there is not generic competition, even if there's only one generic drug, that doesn't necessarily mean that it's any cheaper. Right. Or cheap. Right. Exactly. I think that, you know, yes, it is something that we should be monitoring. You know, the budget also included biosimilars participating in the budget that passed last week, not the theoretical budget from Monday, including biosimilars counting in the donut hole, which was, I think that actually everyone across the board agreed was something that should happen. We should not incentivize only the biologic. There should also be that 50% discount, or now changed to apply in the donut hole as well. I take your point that generics are also expensive. It's something that folks don't often talk about. I think there's this assumption that generic drugs are, $1 or $2 pills or a couple pennies or what have you. That's not necessarily the case. But I think also to your point, it is not necessarily in the spotlight of the issues that people are necessarily focused on when they're talking about total spend. I think encouraging the use of generics, I know, and this is completely out of my space, it's more the help committee. I know that the FDA is working quite hard and diligently to approve applications for generic drugs to bring that competition to the market. I know other folks in other committees have talked about various ways of encouraging not only generic utilization, but bringing generic competition more to the forefront. I think that's fine. But, I put it, I think in terms of our conversation today, we really are talking about dollars and cents and protection for those beneficiaries that this gentleman was talking about before, whether it's generic or brand, and what that kind of financial component is for the patient. So I take your point, and I think it's something that should be part of whatever discussion.
Is there anyone in the back? Anyone in the back? Yes. Okay.
I'm Dr. Caroline Poplin. I'm a primary care physician. I'm also an attorney. We represent whistleblowers who bring off-label marketing cases. We just settled one against Celgene last year for $280 million. Celgene's original product in 1998 was thalidomide. It was approved for a skin disease associated with leprosy, and it was sold for cancer. Now you know how much it costs to manufacture thalidomide. But it was priced according to the diseases for which it was being marketed illegally. Now they made a new one based on thalidomide called Revlimid, and it was priced even higher, and doctors started using thalidomide because it was cheaper. So they raised the price of thalidomide. How can you have competition if there's no competition on price? The competition is always on quality, and these drugs are marketed to be, quote unquote, different. They're marketed as brands. And if you only have 2 or 3, what kind of leverage does an insurance plan have to get the price down to, say, the European level? That would be for Mr. Holtz-Eakin.
I'm not very... Okay.
I said I wasn't going to talk anymore. No, I think in the competitive space, we've seen a lot of examples where the key number is 2. Like if you have 1, we saw that when we launched the Hep C drugs. When we go from 1 to 2 to 3, you do see dramatic increases in competitive pressure. Is that competition, textbook perfect? Probably not. But what you really want to do is try to get as much entry as you can. That in the end is the only way to solve for lower prices. I don't think you want to necessarily aspire to European levels, which are not market-driven prices, right? And one of the things that happens is that we end up footing the research bill for the global pharmaceutical market in a great way. And so that's a different issue and a tough one.
Okay, well, we're out of time for this panel, and I'd like to thank the panel.